Okay, let's hear it for the policy panel again. That was really great. And that's the thing. Patients are powerful, and we want to empower you. It's very important to share your voice, speak on behalf of your community, on behalf of yourself, on behalf of your cause. And anything that the CLA can do to help fortify that, please always know we are a resource for you. So, day one, part two. Also, what did you think about the food? I think the food's been really good, and the staff is really wonderful here too. So just want to make sure we appreciate that, and our tech team is helping everything run smoothly. Thank you so much. Meredith asked me to give you a quick update that if anyone's vying for that iPad today, Thursday's iPad, make sure that you drop your passport into the bin on the registration desk, and we will pull that before Dr. Babbage, the last session. Okay? So, it is my pleasure. This session is autoimmune and rare liver diseases for the afternoon. And we have our keynote speaker, who's used to be here in Pittsburgh, but is now in Texas, Dr. Akshata Moghe. And she's a great pal and very passionate about the work that she's doing for patients with rare liver diseases. Let me get, here we go. Not used to using my phone as a. So, Dr. Moghe is assistant professor of gastroenterology, hepatology, and nutrition at the University of Texas Health Science Center in Houston, Texas. And she did her fellowship here in Pittsburgh and worked with the Pittsburgh Liver Research Center under Dr. Moghe, who I see over there. Her clinical interests focus on chronic liver diseases, hepatocellular carcinoma, and rare liver diseases, including hepatic porphyritis, and serves on the scientific advisory board of the United Porphyritis Association, contributing to advancements in the understanding and treatment of this rare group of disorders. So let us bring Dr. Moghe up to give the keynote, and then we'll launch into the panel discussion and then the breakout sessions. Thank you.
Okay. Well, thank you, Susanna, for that introduction. So, I'll be doing a quick talk today because the main point of the afternoon is to have the panel with our patient advocates and our researchers. So, this is like a quick intro to autoimmune and rare liver diseases. My name is Akshata Moghe. As Susanna mentioned, I'm a transplant hepatologist at the University of Texas Health Science Center in Houston. Okay, let's show. These are my disclosures. So as an overview in this talk, we are going to split it up into two parts: autoimmune liver diseases, in which we'll kind of focus more on autoimmune hepatitis, the more common of the autoimmune liver diseases, and PBC, or primary biliary cholangitis, and then PSC, primary sclerosing cholangitis. And then our panel is going to have patient advocates for alpha-1 antitrypsin deficiency and Wilson disease. So we'll touch upon what these are, and I'll also talk a little bit about acute hepatic porphyrias, which is the area in which I do both clinical and research work. So what is autoimmune liver disease as a whole? So we all know that we have an immune system. That immune system is supposed to ward off external antigens, external toxins. For example, if you're going to get a virus, you get infected with a virus or a bacterial infection, your immunity is supposed to protect you from that. This immune system does not attack organs in the body. We are actually immunotolerant. Our organs are tolerant to that immunity. But what happens in autoimmune liver disease is that this tolerance breaks down. So the body's own immune system attacks the liver, and depending on which part of the liver it attacks, you can have different autoimmune liver diseases. When there is autoimmunity, when your own immunity is attacking your liver, these cells are attacking the liver and causing inflammation. So this inflammation is what leads to a flare or an episode of autoimmune liver disease. Autoimmune hepatitis is what we are going to start off with here. And what we know is that there are two components to this. There is a genetic predisposition, and then there's an environmental trigger. What happens is that if you have this genetic predisposition, and we really don't know the specifics of that, we check for some autoantibodies in the liver clinic, but we don't exactly know how to predict who has this genetic predisposition. But if you have that, and then you have an environmental trigger, which could be an infection, it could be a medication you're taking. For example, the most common UTI medication, nitrofurantoin, can give you autoimmune liver disease or a flare of autoimmune hepatitis. But this trigger can then cause a failure of that immunotolerance or that immunity that is actually, your liver is actually tolerant to that immunity, but that breaks down. And now when those T cells, which are immune cells, attack parts of the liver, there is inflammation. This inflammation, if it carries on for too long or happens too often, can cause more advanced or chronic liver disease, fibrosis, and finally it can cause cirrhosis. Presentation in autoimmune hepatitis is pretty varied. It could be completely asymptomatic. It could happen that you go to your PCP for your annual physical and the labs show elevated liver enzymes, and that's how it's discovered. But you can have a presentation where it's also very severe. You can come in with liver failure. You can come in with jaundice, nausea, abdominal pain. So it's really a spectrum. Autoimmune hepatitis occurs at all ages. It's more common in two zones, though. It has a bimodal presentation, so it presents more in your teens, 20s, 30s, and then it can occur more in your 50s and 60s as well. Occurs in all ethnic groups, but there are some differences which we'll talk about in the breakout sessions. And autoimmune hepatitis is more common in females. So there is a 3-to-1 or 4-to-1 ratio of females to males for autoimmune hepatitis. The prevalence in the US is 1 in 30,000, so it's a rare disease. And then very broadly, how do we diagnose it? We diagnose it with a few tools in the liver clinic. So the patient might come in with elevated liver enzymes or jaundice or abdominal pain. Once we see that the enzymes, AST and ALT, are elevated, we actually want to rule out all the liver diseases that we can check for. So we check for hepatitis A, B, C, we check for hemochromatosis, we check for Wilson, we check for alpha-1 antitrypsin deficiency. If all these are negative or these don't show up, we are also checking for autoantibodies for ANA, AMA, ASMA. Depending on whether these antibodies are positive, everything else is ruled out, we have a suspicion for autoimmune hepatitis. Once you have a suspicion, though, the diagnosis needs a liver biopsy. So we do a liver biopsy. The usual typical picture on a liver biopsy is something called interface hepatitis. So you see inflammation between the lobules, and you also see plasma cells, which is a characteristic of autoimmune hepatitis. Once you have that on a biopsy, the proof is in the pudding. That's kind of what you need for diagnosis. There are different systems, though, some simplified diagnostic criteria that help you, say this is definitive autoimmune hepatitis versus maybe probable. But really, once you have it on the biopsy, our approach is to go ahead and treat. Because whether it's definitive or probable, we are still going to treat the patient and treat the flare. Treatment is steroids, which, steroids suppress immunity. They kind of calm down inflammation. So most autoimmune diseases are treated with steroids. In this case, we use prednisone. Depending on how severe the disease was or the flare was to begin with, we can go anywhere from 20 to 60 milligrams per day. Budesonide is a type of steroid where there is what we call systemic sparing. So steroids have a lot of effects on the human body, right? There's sleeplessness, there can be irritability, there can be weight gain, diabetes. What budesonide does is that it's an oral medication, but the first pass is through the liver, as all medications. It kind of is broken down and used in the liver. So the thought is that the liver is seeing all of the steroid and your body is being spared. So if we can use budesonide, it helps because you can try to avoid the side effects of steroids. The unfortunate part is that budesonide is not as effective as prednisone. So in a lot of cases, you might try it, but you might have to just use prednisone to be able to effectively treat the flare. And then once you've started with prednisone, you've induced remission for a week or two, we use azathioprine, which is not a steroid. And the point is to kind of spare the steroids. So you're trying to use azathioprine to get the patient off prednisone. You know, when patients ask about treatment and how long this is going to be, I usually tell them it's likely going to be lifelong. It's oral medications, but likely lifelong, because we know that when we withdraw these medications, the chance of a relapse is very, very high. And the whole point in autoimmune hepatitis or any autoimmune liver disease is to try to prevent these flares, prevent the occurrence over and over again, because that's what causes ongoing inflammation. That's what is causing more fibrosis and cirrhosis. So as long as you're keeping it contained, you're actually protecting any progression of liver disease. So you could try to withdraw treatment very slowly and gradually. Once you're in remission for 2 years, that's the minimum that we want. But the likelihood is that there's going to be a relapse. And if there's a relapse, we usually go back and never stop again. So, I focus mainly on autoimmune hepatitis because all the concepts are pretty much the same across all autoimmune liver disease. But I'll highlight the differences for PBC and PSC. So PBC is another autoimmune liver condition. Here, the autoimmunity, or where your T cells, your immune cells are attacking, are the small bile ducts in the liver. So as opposed to the entire liver, the bile ducts are mostly being affected. When those are affected, the bile kind of stalls. It's not flowing out correctly, so there's jaundice, buildup of the bile, you become yellow. But the stalled bile causes inflammation and fibrosis or scarring in the liver, and then eventually can lead to cirrhosis. Again, we are thinking that there's a genetic predisposition, but also there are some environmental triggers that push you over to getting PBC. And this is even rare. Even more rare than autoimmune hepatitis. Only, the numbers look strange, but those are the numbers out there in the literature, 19 to 402 cases per million persons, very, very rare. Again, more in females, and the diagnosis is usually in the 30 to 60 age group. The interesting part about PBC is that we know that if a person has PBC or has a proven diagnosis of PBC, the chance that a first-degree family member, like a sibling or a parent or a child, will have PBC is 100 times higher, which is, it's not double or triple, it's 100 times higher. So we do want to keep that in mind when somebody is diagnosed with PBC. In addition to the varied presentation that you can get with autoimmune liver diseases, PBC has a characteristic symptom of pruritus or itching. So this is something that we kind of, if your patient comes to you and tells you that along with the fatigue, they have itching, we really want to look into whether this is PBC. Labs-wise, as opposed to autoimmune hepatitis, where we saw more AST and ALT enzyme elevations, we see more elevations in alkaline phosphatase. And the autoantibody that we are checking is the antimitochondrial antibody, or AMA. It is positive in a majority of PBC patients, so a very important antibody to check. And then finally, we do a liver biopsy to prove the diagnosis before we commit somebody to therapy. Therapy is ursodeoxycholic acid, which is a pretty effective therapy in a lot of patients. We use it 13 to 15 milligrams per kilograms per day, and it's very well tolerated. if you don't, and that's our first line treatment, but if you don't respond very well to it, there are a lot of new drugs in this space, and you'll see some of them outside at the exhibits. Obeticholic acid, which came out several years ago. The unfortunate thing about obeticholic acid or Ocaliva is that it actually also causes pruritus or itching in patients. So it's a lot of patients, even though their labs look like they might be improving, end up having to stop this medication because the itching is actually worse. We use fibrates, which have a really good effect, not FDA approved in the US, but off-label, as in the FDA approved in the US for other conditions, but not for PBC, but off-label for PBC. And then PPAR agonists, elafibranor and seladelpar, which are newer drugs. PBC is a very unique liver disease because along with all the liver manifestations, there are also a couple of other manifestations that we really have to focus on when we see these patients in clinic. One is it can make your cholesterol levels and your triglyceride levels a lot worse, to the point that you can have all these skin manifestations of xanthelasma, which is like lipid deposits under the eyes. Your risk of cardiovascular disease goes up a lot because your cholesterol is uncontrolled. So we focus on that. We try to reduce and manage the elevated lipids, elevated cholesterol with a statin medication. The importance of fibrates is that fibrates not only affects PBC as a disease process, but fibrates also are lipid-lowering medications. So fenofibrate or bezafibrate can be used as a twofer for helping both PBC management, but also cholesterol management. And the other thing is, most cholestatic liver diseases like PBC affect bone density. So we know that bone density goes down when you're living with PBC, and that is something that we again focus on, manage it, treat it, check for it using DEXAs. Patients with PBC can often have other autoimmune and rheumatological conditions, Sika syndrome, Sjogren's syndrome. So something to keep an eye out for, because they might need separate treatments for those conditions, and they might be getting missed because the patient just doesn't realize. Maybe they have dry eyes, but they just ignored it. They didn't think it was a true problem. They never mentioned it to anybody. But if you ask them specifically about it, they will tell you, yes, that this is a problem, and then you can address it. So something to just keep in mind and check. Switching gears to PSC. So just like PBC, PSC also is an autoimmune condition that affects the ducts in the liver. But PBC affected the small ducts, and PSC affects the larger ducts, the main duct that goes into the liver, which is the extrahepatic common bile duct, but also the intrahepatic ducts. And what it does is that these ducts get inflamed when the inflammation is resolving, they get strictured. So now that nice open channel is not a nice open channel, it's strictured in many places, so it leads to more accumulation of bile. Again, the same problems with fibrosis and cirrhosis if the bile is there for a long time and there's ongoing inflammation. Prevalence, again, is pretty low. It's 1.5 in 100,000 persons, so again, very, very rare condition. This condition, though, is more predominant in males, so there is about 70% of all those who are affected are males. The diagnosis is pretty early, in the 40s, 30s, 40s. And the other thing to remember about PSC is that there is a connection with IBD, or inflammatory bowel disease, specifically ulcerative colitis. So if we see a patient in clinic, we diagnose them with PSC, we do have them get a colonoscopy or ask them about a family history, ask for a history of any changes in bowel habits, family history of IBD. And these patients are actually supposed to be getting colonoscopies every 2 years to see if IBD is developing. That needs a separate treatment. So we want to not miss that. And ongoing ulcerative colitis that is not being addressed is actually a risk for colon cancer, which anyways is on the rise in our youth. So something to focus on specifically for PSC is getting a colonoscopy for these patients. Again, the presentation is quite varied. Fatigue, jaundice, pruritus, Sometimes it's actually seen on imaging. So the way PSC appears on a scan, especially like an MRI of the liver that you might get because you were in a vehicular accident or you had abdominal pain, is what they call classically a string and bead appearance. So it looks like every time there is a stricture in the bile duct, it looks like a string, but where the bile duct dilates after that, it looks like a bead. So it's almost like a beaded string. And if you see that appearance, then you're thinking PSC, and that's actually one of our diagnostic features for PSC. Labs show elevated alkaline phosphatase, just like PBC, so you can't tell them apart unless you're doing all your workup and doing a biopsy. PSC specifically is a risk for two cancers, cholangiocarcinoma, which is a cancer of the bile ducts in the liver, but also gallbladder cancer. So we do periodically scan these patients to see if we are seeing any cancers, to detect them early, because early detection is, these cancers are then amenable to treatment. And the unfortunate part about PSC is that there are no good treatments in this space yet, no specific therapies for PSC. A lot of hepatologists and other doctors will use ursodiol or ursodeoxycholic acid, which we use for PBC, because the overall concept is that ursodeoxycholic acid helps improve cholestasis. But it is not specific to PSC. It's not actually guideline based. It's something that we use because we know it's harmless and we hope it's helpful. But this is a space where there's a lot of ongoing research, a lot of push with funding to try to come up with appropriate targets and appropriate therapies to address specifically the disease process in PSC. Okay, so shifting more to rare diseases that might not be autoimmune, more genetic rare diseases. And I want to say a few words about three of them, specifically because we are going to hear from our patient advocates. And for those who might not know a lot about these conditions, it's just like an overview. So the first one is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is an enzyme in our body used for various purposes, but there are some specific genotypes. So this is a genetic condition where some genotypes might have less of the enzyme. And if you have less of the enzyme, you have issues in specifically two organs in the body, the lung and the liver, and sometimes in the skin. And in this condition, it can go undetected for a really long time because there's no real test unless you check the alpha-1 antitrypsin level. So unless you had a liver issue and somebody checked that level, you would not really know until maybe you had progressive disease or a complication from the deficiency. In the liver, we can give back this enzyme. We can give alpha-1 antitrypsin as a therapy, but unfortunately, that is not effective for the liver per se. It does help in the lung condition with alpha-1 antitrypsin deficiency, but it's ineffective in the liver. These patients, again, even before we develop cirrhosis in these patients, we want to screen them for liver cancers because they can occur even before the inflammation and fibrosis and cirrhosis has set in. Wilson is the second condition that I wanted to talk about. Again, a genetic condition. It is what we call an autosomal recessive condition. So you need two defects in your genes. So it's the ATP7B gene that is defective, but both your genes have to be defective, the one you got from dad and one you got from mom. And if both are defective, there can be a problem in copper transport in the liver. So copper, is a metal and a mineral in the body, and there is a transport system in the liver cells for copper. But if you have Wilson, what happens is that this copper is not put out of the hepatocytes or the liver cells, and it actually leads to accumulation of copper in the liver. Also in other tissues, like the eyes, where you get something called Kayser-Fleischer rings, you can have deposition in the brain, really. So you can have some psychiatric manifestations as well, some motor manifestations. So kind of a diverse presentation and very hard to diagnose because this person might present initially with a movement disorder, or they might present with just some rings around the eyes that their PCP saw, and may not have any detectable liver disease to begin with. But whichever person, whichever healthcare physician provider ends up seeing this patient, whether it's a neurologist or a hepatologist, it's imperative that we check for all the organ manifestations and plug them to the right specialty, right people. So this is a condition where we really have a multidisciplinary team, and that team is so important for taking care of this patient as a whole, because otherwise you're addressing a part of the problem and not really addressing the entire problem. Prevalence-wise, rare again, 1 in 30,000 persons. And in this condition, males and females are equally affected. Females tend to have more severe disease for some reason that we don't completely understand. And then treatment-wise, we treat this with chelation of copper. So basically a medication that binds copper and eliminates it from the body. And we'll hear more about it from our patient advocate. And then finally, and this is the last condition we'll talk about, is acute hepatic porphyrias. And we don't have a patient here or a patient advocate here today for porphyria, but I wanted to mention that because I see a lot of porphyria patients, and again, a very rare disease. So what porphyrias are their defects in the heme biosynthesis pathway. So our body makes heme, which is an important molecule that goes into hemoglobin, which is everywhere in our body. And this pathway has 8 steps, and each step of that pathway is regulated by an enzyme. And if there's a defect in that enzyme, it can lead to a porphyria. So there are 8 different types of porphyrias, actually. And 4 of them are based in the liver. What that means is that if you have a defect in that causes one of those 4 porphyrias, the toxins are accumulated in the liver. It manifests with abdominal pain that's recurrent, severe, goes undiagnosed for years. The average diagnostic delay in porphyria patients is about 15 years. So you go a decade and a half with all your problems without a diagnosis, which is a huge, huge time to go undiagnosed. Prevalence is low, 5 in a million persons. And along with the abdominal pain, as the disease progresses, you can have neurological signs and symptoms, hallucinations, tingling, numbness, paresis, sometimes paralysis. So a lot of the times, if you've heard of the condition Guillain-Barré syndrome or GBS, patients get diagnosed with GBS and treated as GBS, but what actually the condition was a porphyria attack that was severe enough to cause paralysis. And this has been now published quite a few times, especially because we saw GBS being diagnosed a lot more during COVID. And when patients got tested for porphyria, when they were diagnosed with GBS, they actually had porphyria. And the unfortunate part is that, GBS is hard to treat. You treat with IgG, IVIG, but porphyria could have been treated with the specific treatment. There are specific treatments for porphyria, and that could really have helped the patient, which we kind of missed because this happens with all rare diseases, right? If you have to really think about, have a low threshold to test for it and a high suspicion to test for it. So rare diseases suffer from lack of awareness, lack of knowledge, what to do, when to test, how it presents, and porphyrias are one of them. Treatment is, depending on the severity of the condition, something as simple as carbohydrate loading, giving the patient dextrose, asking them to eat more carbs or candy can actually help an attack of porphyria. Supportive care for the pain that they're getting, which helps a lot because the pain causes hypertension, high blood pressure, causes tachycardia, or your heart rate to go up, can give you seizures as well. So you want supportive care in terms of specific treatments for all the symptoms you're experiencing. And then hemin and givosirin are the specific treatments that actually target the enzyme that is deficient in porphyria. So I'll stop there with this last slide that to kind of open up the panel that we are going to have next and to say why this is important. So the importance of talking about autoimmune liver disease and rare liver diseases are that they're not as common as some of our more common liver diseases, right? They're not as common as fatty liver from metabolic dysfunction or alcohol or even hepatitis C. They're not as easily detectable either. You have to really have a high suspicion. You have to have the tools to test for it correctly, and then the tools to interpret your test correctly. So for those reasons, diagnosis can be delayed for years in these patients, which is really something that needs to be intervened on, because when you're delaying diagnosis for years, months, a decade at a time, the diagnosis is being delayed, but also the disease is progressing in the meantime. There's no treatment for it, there's no management, not only the physical disease, but the emotional burden of having symptoms that nobody can diagnose is huge. When the disease progresses is when complications start to set in, and then sometimes it's a bit too late. You already are cirrhotic, or you already have irreversible neuropathies like in porphyrias. So you want to be able to diagnose early, and that's the reason why we are all here today to talk about some of these conditions, spread the word, to be able to think about them sooner in our practice. And the third thing is that because they are rare, there's not been that much of a focus for drug development. So we want to push that as well. We want to back up the research that goes into these rare diseases and autoimmune liver diseases, and then also help with maybe subsidizing treatment, because treatments are expensive. These are orphan drugs because the condition itself is rare. And then finally, I want to thank all the support groups and advocacy groups that are here today for all liver diseases, because really, everybody's working in their own spaces, but the impact that advocacy and support groups have is huge, and is more widespread than a single physician or a single pharmacist can do. So it is truly great work, and thank you to everybody who's doing that. With that, I'll stop, and I can take some questions right away. Thanks.
Can I ask you a
Yes.
question?
Yeah.
I had a GBS event, but I live with CIDP. Has there been any research on CIDP maybe being mistaken for the
It has. So we know that any kind of, so the
good,
reason I
thank you.
say that is not directly CIDP, but it has been pretty much a similar scenario, where because you had a condition that was, I guess it was more known to be correlated with GBS. You got diagnosed with GBS, but you were not tested for porphyria. So in those conditions, we really want to go back and see what your initial symptoms were, because porphyrias, we know that they manifest with chronic abdominal pain, neurological symptoms. So if you had that,
If I still have it though, that's why I live with the CIDP. Could you still have the
yeah, it's easy to test. You have it forever. You have it forever. You can manifest at different times in your life as an attack or a flare.
Yeah.
And it's very easy to test, so it's something,
Okay. Thank
to
you.
get us. Yeah.
And then I did have a question about Wilson's really quick.
Yeah.
Would Wilson's affect your mobility?
It does. So it has, and I know somebody is going to talk about it on our panel, and they'll go into more detail. But yeah, it has motor effects.
Thanks.
Yeah.
So for the porphyrias, how does one diagnose the porphyrias? Is it easy or difficult to diagnose? And
So, sorry, did I cut you short?
no, I was going to ask two questions, but that's okay.
Okay. So let me answer that question first. So I say it's easy and it's hard. It's easy because it's a simple single urine test. It's a random urine sample that we check for something called porphobilinogen, which is what goes up in your body when you have porphyria, and ALA, which is also another toxin that goes up in your body. So it's as simple as that. You don't have to do more than that. But the hard part is that, first, people might not know what to check. Second, it's not a test you can easily order in your EMR. So if you're going to a doctor's office and they work in Epic or something, they might not find the test over there. It's a send-out test that we send to Mayo or Quest or Lab. All the labs do it, but you should know which one to order. And if you know which one to order, then it's a simple test to do.
Okay, and for like acute hepatic porphyria, do you know about treatments that are available?
Yeah, so the two specific treatments that are available are hemin, which is essentially a heme product. So when we use it during an acute attack. So if somebody's having a flare or an attack of porphyria, it's an infusion that we give. It's a daily infusion that we might need 2 or 3 days of therapy to improve the symptoms. So for example, something like paralysis will improve in that 3 or 4 day span if you're doing hemin every day. The other medication is givosiran, which is actually unique. It's an RNA inhibitor therapy. It's a small molecule. What we do with that is that we use it prophylactically. So if we know you have porphyria, and say one of the biggest triggers for porphyria is menses, the menstrual cycle, because progesterone, which is high in the second part of your menstrual cycle, triggers porphyria. So in women where we know that they get their attack every month because of their menstrual cycle, we can use givosiran prophylactically. It's once a month, and it's a subcutaneous injection. But that has really changed the face of porphyria management because it has, we're not waiting for that attack to happen. We are basically doing something prophylactically.
That's wonderful. Thank you.
You're welcome. Yeah.
So all the autoimmune diseases are more prevalent to women. So what you say it's because of the hormones, as you mentioned, probably progesterone related.
Yeah, so this is very interesting because we don't know 100%. One belief is that women have more immunity, like they just have more immune, and I don't know if Dr. Monga will have some theory about this, but what I know about it is that women have a more predisposition to that immunity going haywire because they're more immune wired to begin with. And but more than that, we really don't know the specifics for why women have more autoimmune liver disease than men do. But when men have it, it's pretty bad. So yeah, it's a great question. Yeah.
Are you seeing with PBC that it's still requiring transplants?
Yes. So, PBC is interesting because there is a good chunk, a majority of my patients, or a good chunk of anybody's practice that is well controlled with ursodiol if it's detected early. So the thing with PBC is if it's detected early, we can use ursodiol and prevent any flare, any attack. So maybe you're taking ursodiol all your life, but your liver disease you're not getting advanced liver disease. You don't need a transplant. So in that sense, there's a good majority of patients that are in that bucket. The ones that are needing transplants are the ones that unfortunately did not really have any symptomatic disease for years, or did not really have any liver, and the alkaline phosphatase is what we look at in your liver test. So when they got their annual liver test, it wasn't very much elevated, but maybe it gets elevated now and then, but it's just missed for some reason or the other. It's missed, and now when you present, you're in your 50s, 60s, 70s, you're presenting with already fibrotic livers or cirrhotic livers, and then we go back and see that this was PBC. So, but that is definitely a smaller part of the PBC population. The larger part is the people who got detected early and now are being controlled and not needing a transplant. I want to add on to that. The other thing about that is that if you have an overlap syndrome, so if you have, because you are genetically predisposed to autoimmune liver disease, sometimes you can have more than one. And I think we have somebody who's going to talk about that. You can have more than one. And if you have an overlap syndrome, you have autoimmune hepatitis along with PBC, that can tend to progress faster. And those patients do need transplants more often than pure PBC.
All right, thank you very much.
Okay.
Interesting questions from everybody.
Thank you, Dr. Moghe. Dr. Moghe, you will be the moderator for this panel? Okay. So we have, if we could ask our panelists to come up, we have Danette Smith. Oh, what just happened? Sorry. Jacob Skurich, Caitlin Ballant, Letitia Marino, and Dr. Paul Monga with the Pittsburgh Liver Research Center. Please join us for the panel. Okay, let me.
Since they might have slides.
You're fine. Hello, hello. Thanks for being here.
So welcome to all the panelists, and thank you for coming. We have 4 patient advocates, and Dr. Monga does research in the space, in the autoimmune and liver disease space. The first panelist that we're going to start off with is Danette. So Danette Smith is a 3-year liver transplant survivor. So congratulations. She was diagnosed with not one but 2 rare diseases, Stills and Wilson. She's an ambassador for Mid-South Transplant Foundation in Memphis, Tennessee. She mentors patients there at the Methodist University Transplant Center in Memphis before and after transplant. She currently speaks all over the country for Mid-South Liver Alliance. At one point of time, she was a kidney and dialysis clinic head of research and had over 20 different DaVita units under her supervision. And now she's doing great patient advocacy work, which she will talk about today. So welcome and thank you.
Thank you. Good afternoon. Thanks for having me. My name is Danette Smith, and I am a patient advocate. I'll just start off by saying I want to talk a little bit today about because of my transplant I get to. My journey with Wilson's disease started around 2016. I was diagnosed with a tick bite, they thought. And I was in the hospital for about 3 weeks, but the doctors didn't know exactly if it was a tick bite or what it was. No answers. They just sent me home and said, we don't know. Then I saw a rheumatologist and he sent me to Vanderbilt. That's in Nashville, Tennessee, and I was diagnosed with Still's disease. What Still's disease is usually a juvenile disease that affects the joints and muscles, but it can be adult onset, and I was one of the lucky ones that got it because it's very rare. Its symptoms were high fevers, joint pain, joint swelling. You couldn't sleep because of the fevers, and the fevers usually start at nighttime and usually go all night long. So the treatments at the time were chemo and methotrexate and steroids. So I had 2 rounds of chemo and then weekly infusions, and then I stayed on steroids for a year and at 60 milligrams a day. So I look like the big, the blimp, I look like that with the big face. Then about 2018, I had all the treatments that were available for Still's disease, and I progressively got worse and worse. I ended up, and somebody was talking about mobility with Wilson's disease. I ended up in a wheelchair. I couldn't walk, and I could not. I had Parkinson type symptoms. I shook a lot, not just only my hands, but my whole body shook. And so I ended up in a wheelchair, not able to take care of myself. So I moved in with my mother, which is a nurse and a drill sergeant. I didn't know she was that. Anyway, my symptoms kept getting worse and worse. So I was sent to Dallas, Texas, to a doctor that was supposed to be a specialist. He threw up his hands and said, I don't know. I went to Louisiana. I don't know. But finally, I was sent to a hematologist there in Memphis, Tennessee. And he said, let's just try checking your copper. And I had been told my liver enzymes were elevated for many years, but they would just watch it. And so he checked my copper, and yeah, I had Wilson's. I had the Kaiser flasher rings that were so obvious that you could see them with your bare eyes. And my eyes were golden. My skin was gold, but these doctors had no clue what was going on with me. And I saw a gastro doctor. He did a liver biopsy on me, and he said, you're stage 4 liver failure. You're going to have a transplant. So I went to Methodist University Transplant Center in Memphis, and they treated me for liver failure. And my MEL score kept going up and down, up and down, up and down. And they weren't for sure if I was a true candidate for a transplant. So I battled with that. And along the way, my ammonia level became so elevated that when I went into the hospital March of 2021, I was put on a ventilator for 4 months. And my mother was told that I probably would not come off that ventilator, and that if I did, I would have severe brain damage because I had loss of oxygen for a long period of time. And so, we battled with that for 4 months. And then when I did come off the ventilator, I had damage to my vocal cords. I couldn't speak. I couldn't swallow. Couldn't talk. I had to relearn how to walk, talk, work my cell phone. No clue how to work the cell phone. No clue how to work the TV. None of that. So, it just did a lot of damage that way. My mobility was very, very off. I had to walk on a walker for a good while. My mom, though, through all of that, she's a nurse as well. And she was very deliberate about me getting well. And thank God that she was, because I probably had no clue what was going on at the time, because my mind was just cuckoo for Cocoa Puffs, really. And her determination and her being an advocate for me when I could not speak up was a huge blessing for me at that time. I'm able to tell my story today because of my mother and Methodist University transplant team. They are wonderful there. They took special care of me. Let's see where I'm at. It was a long recovery, a very long recovery. I also had torn my rotator cuff. I had a fall before I went on the ventilator, so my rotator cuff was torn. So I couldn't move my arm, so I had to go through occupational therapy and physical therapy at home when they discharged me with my mom, again, the drill sergeant. I have full motion of my arm. So in January, on January 19th of 2022, I entered the hospital for the very last time before my transplant. My doctor, Dr. Nair, there told me that I would no longer be able to go home until I had a transplant. And I said, no, I'm not dying in this hospital. You're going to send me home. Because, I was at the point where, you have to be well enough to receive the transplant, withstand the transplant, but sick enough to be approved for one. At that time, I was not listed. So on January the 29th, I got listed, and then 4 days later, I got my liver. Thanks to a generous donor at the end of his life, he saved mine. It was a hard recovery, but man, I felt better. I mean, like as soon as I got that liver, I was ready to go. I was ready to walk down that hall without assistance. You know, my color was good. I was like, Mom, look at me. I'm actually looking pretty good right now. My hair was lopsided, you know, but to me, I was looking good. Also, I had other autoimmune diseases that I was dealing with. I had lupus and I had diabetes, Sjogren's syndrome. I mean, you know, you get one, you get them all. I think it just follows. I'm thankful for the journey the Lord brought me on, because if I hadn't been through the journey, I couldn't stand in front of you today and tell my story. And because of my transplant, I now am an advocate for donor awareness. My brother passed away this year in January at the age of 46 from heart failure. He was also a donor. 2 people are seeing because of his donation, and 78 children benefited from his skin and tissue at the Memphis Burn Center. I can stand in front of you today and be a witness to what donors can do. I now do work for Mid-South Liver Alliance. I'm an ambassador for Mid-South Transplant. And last year, I went to the Transplant Games of America, where I competed in Lyrics for Life. That's a singing competition. I also ran my first 5K after transplant. I was an avid runner, a marathon runner, before I got sick. And so I cried the last mile, saying, woohoo, I'm running again. Because of my transplant, I can sing again. I also went to Washington, D.C. last year and attended GLI with Mid-South Liver Alliance, where we were able to meet with our congressmen and women and voice our concerns about the liver world, per se. I stand before you today in awe of what God has done in my life since my transplant, and I would like to end with this. There's a moment in every transplant journey that isn't on a medical chart. It's not the surgery, it's not the test results, it's not the discharge date. It's the moment a patient finally believes, I'm going to make it. You can hear it in their voice, you can see it in their eyes. The fear softens, the hope settles in. It's spiritual, it's emotional, and it's powerful. I've witnessed it. I've lived it. Sometimes that shift comes after hearing a peer say, me too. Other times it's quiet when they wake up one morning and realize they're not just surviving, but they're living. It happens on both sides, pre and post transplant. That moment is why I do what I do, storytelling. It's not just care, it's belief building. A belief can change everything. My moment was February 2nd of 2022. Is there a picture? That was my moment. The Coke in my hand. Thank you for allowing me to tell you why, because of my transplant, I get to.
Thank you, Danette, for sharing your story, and not only with us, but for sharing it continuously on so many platforms. And like you said, that storytelling goes a long way in helping the person in front of you. So thank you. Moving on, our next patient advocate is Jacob Scritch. Jacob is a liver transplant recipient, and he got his liver transplant at the young age of 9 years old. He received his liver transplant at UPMC Children's Hospital in Pittsburgh. And since then, he has received his bachelor's in health science at Lock Haven University and is currently in the process of receiving his master's degree in biomedical sciences at Geisinger. His ultimate goal is pursuing a career in medicine. He's currently also working on the Partner Advance project. Correct me if I don't say it correctly. Is it Advance project? As a patient representative on the leadership team. Okay, welcome.
Thank you. I don't know if that's all. Okay. Sorry. So yeah, so 15 years ago on July 21st, 2010, I received my liver transplant. And if you rewind to, years prior to that, when I was born, a couple days after, I was diagnosed with alpha-1 antitrypsin deficiency. It was an early diagnosis. Normally, like you said, it's not diagnosed that early. Fortunately, my pediatric GI, they tested for it right away because my brother was born and he had the same condition. For him, he didn't have any development of cirrhosis or any sort of liver-related issues. For me, I wasn't so lucky. For the next couple years, I started with having GI appointments with my pediatric GI every couple months, and we're slowly weaning into doing it every year, appointments like my brother had done, which was something that we were all comfortable with. We got to the point where I was doing appointments every 6 months, and then in January 2006, I woke up one day and I just remember my neck being extremely sore, and I didn't really know what was going on. It was painful to swallow, and my lymph nodes were swollen beyond belief. I mean, it was visibly, I could feel it, I could see it. I mean, my family could see. We went to the emergency room to see, we didn't know what was going on. They ran some tests, and my liver enzymes were very abnormal. So we scheduled an appointment with my pediatric GI as soon as we could get in, which ended up being like a week or so later. And the team there was concerned that there was beginning to be development of some cirrhosis, but they wouldn't be sure without doing a biopsy. So that was then later scheduled for June of 2006. So for some context, my mom she works in education, so she's off in the summers. So it kind of worked out well where we could have that kind of time where if there would be any sort of recovery, it would work out to have a caregiver not have to take off time. So then I had that biopsy done in June, and I remember getting discharged. I was discharged at noon. I can't remember the day of the week, but I was discharged at noon, and by 4 p.m. that same day, my family was called from the pathology team, and they said that Jacob he has cirrhosis. It's rapidly developing. You need to we need to have another appointment to get you in contact with a transplant team to decide what is the next, where you'd like to take the next step. After kind of doing a little bit of background research and looking into pediatric transplant centers within a reasonable distance, we settled at Pittsburgh Children's Hospital, and I'm very fortunate that we did. It was a wonderful experience there. So we met with them in July of 2006, and we had a consultation, and they kind of told us that, yeah, he's going to need a transplant, but kind of like how Danette said, he's not really sick enough to be on the transplant list. So that was kind of a shock for our family, kind of hearing that, yeah, your kid's sick, but not quite sick enough. And it's kind of an interesting thing to navigate that, you kind of have to watch them get sicker before they can really do anything to correct it. So that took about a year until I was put on the transplant list. And then in 2007, I was still able to do most of the things that I did prior. I still was a pretty active kid. I grew up in rural central PA, so I was outside and doing all the things that a kid in rural PA does. I was still able to play baseball, and with just some minor modifications, I wore a guard for my abdomen because it was starting to get swollen. I didn't have any, I had the mild restrictions of physical contact activities, trying to reduce them, trying to limit any contact or blunt trauma to my midsection. So then it was in later 2007, we received a call that there's possibly there's a liver that's available, but I was not the main priority patient for that. I was a backup, and because of the proximity to the hospital, they wanted us to go and stay in Pittsburgh. So we stayed in a hotel, and unfortunately for me, but fortunate for someone else, that liver went to a patient who needed a multi-system organ transplant. So that was that. We went home the next day. It was kind of a rush of emotions. On one hand, it might be the kind of end of the being sick time, but also on the other, it's still a big step. So then later on in 2008, we had another call where kind of late into the night, my family got a call that same situation. There's another liver available. You again are the backup. It's not, it's not a guarantee to be going to you because you're close enough. This time, we're not going to have you stay. We're just going to have you stay at home and kind of remain available. So we did that. I took off school. My family, everyone took off work, and we were having issues with phone lines at the time. So the phone call that I wasn't going to be getting that liver went straight to voicemail, and we didn't see it for like an hour. So that was an interesting call to see to hear over voicemail, per my mom, that she told me about that. And then fast forward to 2010 when I ended up having it. So in July, we had. So at that point, we were meeting annually with the transplant team to just kind of monitor progress of the cirrhosis, see if there's anything that was critically developing. At that point, it was definitely it was very visibly getting worse. I was looking sicker. I was not feeling good. I wasn't able to, do the normal things that I did, whether it be physically or just not having energy to do it. And they had pitched the idea of possibly doing what they referred to as a domino transplant, which I can't get into the depth of it. But so that was on. So we actually had an appointment. We had 2 consecutive appointments that week, and they scheduled it on a Friday and a Saturday, which is kind of strange. But they knew that we like to go to baseball games whenever we'd have an appointment and kind of make a trip out of it. So then later I guess Monday that day, we got a call that, hey, there might be a liver available. And my family so after being told about the domino transplants, my parents reached out to my pediatric GI, and because it being a weekend, it was leaving a message for them and asking if they knew anything about them. And at the time, I doubt that he did, because I think that they said they only did 5 at the time. So we were whenever we got the call on Monday, my family didn't really know. There wasn't a ton of detail in it. They didn't know whether it was going to be one of the domino transplants that they were a little hesitant on, just because of how experimental it was at that point. And so we got that call on Monday, and we didn't want to jump in anything. We had already had 2 false alarm situations where they said there was a liver, but it ended up not going through. So being summer vacation for myself and my mom, she was very open to, if you want to have friends over, do that. And, there's not a problem. And my neighbor and I growing up were very close, and she had just got done telling my neighbor's mom, anytime that, his name's Michael, anytime that Michael wants to stay the night or come and hang out, he's more than welcome. You don't need to really ask, just he can just stay there. And so I asked my mom, I was like, hey, can Michael stay the night? And she's like, no. And I didn't know why. And so she didn't want to tell me about, hey, there might be a liver. So she was kind of trying to play that off, that if we had to leave in the middle of the night, she doesn't want to, she didn't want to have someone else's kid with him. So then later on in the night, I think it was probably like 10 or 11 o'clock at night, I was like, hey, can I have something, like, can I get something to eat? She's like, no. And I remember thinking, like, wow, you're being really mean today. Like, I don't know what it is. Like, it was just one of those things. And so then the next morning we woke up and we still didn't hear anything we didn't hear anything overnight. So come morning, we did hear from the Pittsburgh transplant team, and they said that as of right now, it's a go. So head out to Pittsburgh and we'll get like everything started. And this is the first time where they had said to go straight to the hospital, don't go to a hotel. So we went in, we checked in. They took us to 7B, which is the transplant floor, and they kind of went through what to expect, what going under is going to be like, what it's going to be like when you wake up from transplant. You're going to have all these tubes sticking out of you, and IVs and PICC lines and central lines and a whole bunch of stuff. And so we went through that, and then we were told that it was going to be a go. So then by 8 o'clock that night, which it seems like 8 o'clock, but it was a long day. So by 8 o'clock that night, I was in the OR, and they were waiting for, I think my liver was removed by, I want to say 10 or something like that. And then it was, I think 11 o'clock is when the donor liver arrived. And my transplant went through, and everything worked out wonderfully. I didn't have many major I didn't have any initial issues, any hiccups after the transplant. There was some mild, like your LFTs didn't quite go to where they expected right away. It took a little bit of time, but there was nothing that was alarming. And after a couple days, I was out of the PICU and into up to 7B, where the normal recovery, the rest of recovery takes place. And then after about 3 weeks, I was discharged to the Ronald McDonald House. And after like a week there, I remember meeting with Dr. Cindy at Pittsburgh Children's, and we were, it seemed like just yesterday I just had my transplant, and he's like, I think you can go home today. And we're like, what do you mean? Like, and I don't think I can. So he's like, no, yeah, you're good. You're close enough that you can go home today. So we did. We went home. We didn't tell anyone in my family, really. We just kind of packed up stuff from the Ronald McDonald and drove to my grandparents' house. And it was funny enough, my grandmother, she opened the door, and she was holding my, at the time, infant cousin, and she was absolutely startled to see me ring the door, knock on the door, and her answer, and it was me. And so I was discharged then, and it was about a week later, there was some other labs that we had to go back for another follow-up appointment. LFTs were kind of elevated a little bit at that point. They were worried. They did some steroid treatment, and then after that, I didn't have any issues just then. My great-grandmother was alive at the time as well, and she was living with my grandparents. She was very sick. She was in her late 90s, and I was close I'm very close with my family, and was close with them then. I would always play cards with my great-grandmother, and I remember she ended up passing away about 2 weeks after I was discharged. But one of the things before she ended up going on hospice care, she said to my mom, so towards the end of her life, she wasn't 100% sure of everything that was going on at the time, and she asked my mom, she's like, so Jake's going to be home for good? And it was just a couple days later that she was in hospice care, and less than a week later she passed. So that was something that's always been touching to me. And then, fortunately, through having, such a great team at Pittsburgh Children's, they've been awesome. I have since transitioned to adult care about a year or so ago. I only had, went in for they do 5-year surveillance biopsies in the pediatric transplant, or in pediatric liver transplant. It showed some mild cellular rejection that they treated with steroids. Nothing that was extremely alarming, just something that they wanted to take care of. And then the next one, it kind of showed the same. There's some mild cellular rejection. And then in 2021, I had a severe rejection where I was hospitalized for it was the first time in 11 years that I was hospitalized. And, it was kind of wild to, make it that far. And then like, okay, yep, you have to go back to the hospital for, I think I was there for a little over a week, which I felt fine during the time. So it was kind of a shock whenever I saw my lab numbers and they were all through the roof. So like I said, I felt totally fine. I didn't feel sick at all the time, but after some IV steroids for over the course of a week, I was discharged and I've been monitoring it since and haven't had any issues. So they said, it's awesome to kind of be able to have such a good story where, there's a great transplant team to back you, and yeah.
Thank you, Jacob. You're only in your early 20s, and you have a story to tell that started when you were a baby, and it's kind of wild when you even think about that, but thank you for sharing. Our next patient advocate is Caitlin. Caitlin Balland is actually a board-certified nurse practitioner. She completed her undergraduate degree at St. Anselm College with a degree in biology and received her associate's degree in nursing from Revere College. She then went on to get her Bachelor of Science degree in nursing and then her master's in nursing at Western Connecticut State University. She worked as a nurse for 14 years in the surgical and trauma ICU at Yale, the emergency room, the medical surgical ICU at Greenwich Hospital, and the PACU and the IR department at Nuance Health. At the age of 17, she was diagnosed with autoimmune hepatitis, and then in her 30s, she was diagnosed with PSC, or primary sclerosing cholangitis, finally transplanted with a living donor liver transplant in 2021. Thank you for coming, Caitlin, and thank you for sharing.
I have a PowerPoint slide.
You want to stand up here?
Yeah, maybe. I just push this green one, right? Yep. Okay. All right. I'm Caitlin. I'm a nurse practitioner, a runner, and a mom. I'm also a patient who has lived with autoimmune hepatitis for more than half my life. Today, I want to share my transplant journey with you, not just as a personal story of survival, but as a way of showing the touch points where providers like you made all the difference. You'll hear about my diagnosis, my transplant, the complications, the people, the doctors, nurses, NPs, PAs, and whose skill and compassion carried me through. When I was 17, I went to the doctor for a soccer injury. I had bruises everywhere, which felt normal to me as an athlete. But the physician didn't brush it off. He ordered labs. That one decision led to a series of tests to eventually the diagnosis of autoimmune hepatitis. On the outside, I looked like a healthy teenager. Inside, my liver was already cirrhotic. As providers, you know how often patients come in saying, I feel fine, and you know the importance of digging deeper when something doesn't feel right. My diagnosis, my whole future, hinged on a provider trusting their clinical instincts and following the labs, just not on my outward appearance. Loving soccer was devastating. To cope, I started running. In college, one of my professors saw me and said, you should join the cross-country team. I thought he was nuts, but I eventually did. I became the top runner on my team, placed second in New England, and qualified for nationals where I placed 54th. Beyond competition, beyond the competition, I believe that running slowed my disease progression. This part of my journey highlights the attention you probably see every day, the patient who feels fine and insists I feel fine even when the labs say otherwise. That was me for years, running at a high level, all while my liver was quietly failing. My own illness nudged me into healthcare. I studied biology, then nursing, and I worked in ICUs, ERs, and recovery units. Later, I earned my master's, became a nurse practitioner. I now work in primary care and hope to one day work with a transplant team. Being on both sides, patient and provider, gives you perspectives. I know what it feels like to be the nurse running in with critical results, and I know what it feels like to be the patient waiting for those results. The dual lens has helped shape how I practice and how I advocate for myself. In 2013, I gave birth to my daughter, Reagan. She was 5 weeks early, 4 pounds, and a fighter from day one. She was discharged in 3 days, but we had to board her because I was having complications and wasn't ready to leave. Pregnancy was incredibly hard on my liver. I saw firsthand the delicate balancing act providers face, managing maternal health, fetal health, long-term risks, and short-term crises. What stuck with me were the clinicians who communicated clearly, who prepared me for what might happen, and who held space for both the medical facts and the emotions as a new mother. In 2017, before my gallbladder surgery, I was added to the transplant list. They wanted to be prepared just in case anything went wrong. And by 2020, my symptoms worsened. That's when my doctor looked me in the eye and said, it's time to look for a living donor. That shifted us into action. It's something every clinician knows. Patients often need clarity, not maybes. That conversation gave me permission to act, to start a public search. I launched a Facebook page, Kate Needs a Liver. That was the hardest, most vulnerable thing I've ever done. It opened doors to my community, to social media, and ultimately my donor. My donor was Sophie Long. She was 25, a math teacher, a runner, and an employee at the local running store, a part of the same community I was in. On January 12th, 2021, I got the call. Sophie was a match. She went on to donate 60% of her liver to me. She now runs the Boston Marathon every year for the American Liver Foundation. For you as providers, the lesson isn't just about Sophie's heroism. It's about how much the patient's community is part of the care plan. My running community, a local store, and a Facebook post became just as essential to my outcome as the OR team at Yale. The surgery was set for January 26, 2021, but COVID delayed it. On February 2nd, I had a 10-hour transplant. Sophie was discharged after 5 days. I was discharged after 6. It sounded like a success story, and it was, but it didn't stop there. Within days, I faced a hepatic arterial thrombosis, a portal vein occlusion, and more interventions. We all know how fragile those early weeks are. My survival depended not just on the surgeons, but on the vigilance of the entire team. Everyone catching things early, coordinating seamlessly, and keeping me alive. The first complications came quickly. 2 days after I was discharged, I developed a hepatic arterial thrombosis that required a thrombectomy and a stent. Later that evening, I developed a portal vein compression secondary to a localized hematoma with multiple thromboses. A few months later, in September 21, I developed sepsis and was hospitalized again. On paper, these are expected risks, but for a patient, each one is terrifying. I went from celebrating survival to suddenly being back in crisis mode. What mattered most during this period was the vigilance of my team. Every lab, every scan, every time someone said, we need to check this out, those decisions caught things before they spiraled. It was a reminder that post-transplant care isn't just about the OR, it's about the constant watchfulness afterwards. So the first picture is me when I was discharged after 5 days. But then when I developed the portal the clot where they had to reopen me up. So one was like a little bit more emergent, and it was a male surgeon. The top one was a female. might have taken a little bit more time. Okay. The complications didn't stop there. Over the next couple of years, I developed strictures that required multiple drains. In 2022, I was diagnosed with ulcerative colitis. Then in 2023, I had a bile duct inflammation that required more drain placement. By 2024, I was on Skyrizi with my team watching closely for signs of secondary sclerosing cholangitis. In 2025, I was placed on azathioprine because the Skyrizi wasn't helping the ulcerative colitis, but it was lowering my bile salts. I've been under the care of Dr. Boyer since I was 17. He's walked me through every stage. My hepatologist, Dr. Toe, has answered every question, no matter how late or small. The Yale transplant team are miracle workers. But it's not just the technical excellence, it's the way they communicated, the way they guided me and my family through decisions, the way they treated me as a whole person. That's what I want to emphasize today. Patients remember your humanity as much as your skill. I'll always tell people that organ donors are heroes because Sophie is mine. But to this audience, I want to leave you with this. What you do as providers is what gives people like me the chance to be here at all. Every lab you order, every time you explain something one more time, every collaborative huddle you have matters more than you know. I'm here because of one donor, yes, but I'm also because of decades of care from providers who refused to give up, who communicated clearly and showed compassion along the way. That's what I hope my story reminds you of today. And this I call my liver family. 3 of us have had transplants. My donor's there, and then that's the Boston Marathon, so we all get together every year for that.
Thank you, and thank you for highlighting the role of your community, your running community in your whole journey, which seems like was a thread that was binding you right from the beginning. A very inspiring story. Thank you. We're going to go with Dr. Monga next. Dr. Monga is my mentor, so it's an honor to introduce you. He is the UPMC Endowed Chair for Experimental Pathology at the University of Pittsburgh School of Medicine. He's also a professor of pathology and medicine and the Associate Dean for Research for the school. He is the Executive Vice Chair of Pathology and the Chief of the Division of Experimental and Translational Pathology. He is the inaugural director of the Pittsburgh Liver Institute and the founding director of the P30-funded Pittsburgh Liver Research Center, or PLRC, which is only the one of 17 NIDDK-funded digestive disease research core centers in the country, and the only one of 3 with an exclusive liver focus. His lab focuses on liver physiology research as well as the role of beta-catenin gene mutations in liver tumors. Dr. Monga, welcome, and thank you for talking to us about your research.
Well, thank you so much for having me, and thank you to all the folks here for sharing their stories, which really provides fuel for individuals like us to continue to work really hard to identify cures for these very, very difficult diseases. So my topic today is actually not on my own work, but I was asked to talk about some funding opportunities that National Institutes of Health has in the space of rare diseases, autoimmune hepatitis, and others, and also the clinical trials, how differently you have to think about doing clinical trials in rare disease space. So that's what I'm going to talk about. I think I am talking about a little bit of my work in liver cancer with the clinical trials that are happening here at UPMC on Sunday. So I hope to be able to share some of that work there. I mean, you've all heard many, many anecdotes about the rare diseases today. These are just a few numbers. Rare diseases, I think they represent a significant unmet clinical disease, and the numbers speak for themselves. It's over 7,000 rare diseases. They affect about 350 million people worldwide, so it's hardly rare if you kind of take them, put all together. Approximately 30% of these individuals with rare diseases are in fact children, and approximately 80% of these diseases are genetic. And we heard a few examples of that today as well. And very, very kind of sad part of this is that only 5% of these rare diseases have any FDA-approved drugs. So there's a lot of work that needs to be done. It's a major unmet need in this. So as one can imagine, there are many challenges with rare diseases. This rare diseases encompasses a very small group of patients, and hence there is in general, scarcity of patient population that makes it very hard to understand the disease mechanisms that lead to those diseases. It's not one shoe fits all. Every disease is heterogeneous, and there are environmental factors, there are genetic factors that are leading to it. So we need a large number of patients that can be examined for making some accurate diagnosis and their molecular understanding. It also makes it very hard to do clinical trials, because how do you interpret the data? I mean, if one patient responds and 5 others don't, but one patient did respond. So how do you sort of take into account that type of heterogeneity when it comes to rare diseases? So there are unmet needs, and those include we need more research at basic level. We need identification of therapeutic targets. We need to identify scientifically sound biomarkers, which could then help us look at the responses to any particular drugs that are identified. So at National Institutes of Health, there is one particular center called NCATS, or National Center Advancing Translational Sciences, which is really, really dedicated to studying and tackling rare diseases. You can visit the website. There's a lot more information on it. But they're following goals of NCATS, and that's, we want to, shorten the time to diagnosis. As Dr. Moghe said in her talk, the early diagnosis makes all the difference in these patients, because if you leave this disease unrecognized, then there could be times of where the disease has progressed beyond repair, and at that point in time, the only plausible treatment is going to be liver transplant. Also discovering multiple treatments at a time, which really means that you have to understand the molecular and the cellular underpinnings, what's driving disease. So we need a lot of research in that. They want to make it easier and more efficient for scientists to discover and develop rare disease therapies. And because most rare diseases are genetic, the focus has been on gene-targeted therapies. As you all know, the most recent things, in fact, Akshata gave an example of Alnylam's drug that is now being used for porphyria, which is an siRNA-based approach given in a galaxy formulation that just takes that siRNA to silence one of the enzymes that stops the formation of porphyrins. So I think this is the next generation of discovery. So we need to identify those genes that are bad and then either knock them out or repair them using different types of therapies. And I think a lot of that work needs a lot of research, a lot of money, which is what NCATS really provides. And obviously, one thing that is very, very relevant here is we have very few patients with rare diseases. So how do you design clinical trials? And that's work that has been done by NCATS as well. They call this approach as a basket trial approach, which is very commonly used in liver cancer, in general cancer, in oncology field, where you are grouping your patients based on underlying molecular drivers rather than what disease you are suffering. So, and the premise behind, or the precedence behind that is that even though there are several thousand rare diseases, the underlying genetic aberrations may be far fewer and are far more common. So you can manifest with a liver problem or a kidney problem or a lung problem, but you have the same gene defect. So would you have to have a separate clinical trial for a liver, for a lung, for a kidney, or can you all be lumped into that one basket trial? And I think that's something that NIH is really, really, really investing in. And And that's happening in oncology as a basket trial concept, but it's also beginning to happen now in rare disease space as well. And if you would like to kind of learn more about this, again, I would encourage you to visit NCAT's website and talk to even NIH contact Dr. Philip Brooks. And then, of course, there's a lot of other very interesting programs that have been identified, or the money is being earmarked for those, including the NCAT's rare disease research, therapeutics for rare and neglected diseases. In short, they call it TREND. And this really supports the development of research all the way from basic level. And then this particular mechanism helps take that drug to FDA to kind of get an investigational new drug approval. If you realize there's a lot of steps that need to be taken, there's safety studies that need to be done, there's an adequate number of preclinical models that need to kind of show response, but at the end, the patients, they have to be a certain number of patients that have to have a response as a proof of concept clinical trial. And that all of that requires a lot of funds, and the TRENDS program of NCATS actually provides that. And some of the examples I just list there, there has been gene therapy for AADC deficiency that has gained FDA approval now. For Duchenne muscular dystrophy, there is also a therapy available, and NCATS funding has allowed kind of taking all the way from bench to bedside. And finally, there are, because these diseases are, far few and in between, it's important for us to have, a community or a clinical research network which allows physicians to talk to each other across the globe to kind of discuss the common pathogenesis, their own experiences, also having a biobank of tissues so that more research can be done. And it's like we are better together than we do it on our own. And I think that's where there is a special effort by NCATS to create this RDCRN, which is designed to advance medical research on rare diseases by providing support for clinical studies, facilitating collaboration, and to study enrollment and data sharing. And this program was really mandated by Congress via this Rare Disease Act of 2002, which I hope will continue to stay and continue to be a law, as even though a lot of things are at stake under the present administration. And I must say this, that NCATS, based on the initial proposal, NCATS doesn't even exist in NCATS. So there's a pushback. The Senate has stood against that consolidation of 22 different institutes within national institutes to only 7 or 8. And as I said, NCATS, NIDDK, these are some of the institutes that have been funding a lot of research in liver space. Based on the new pushback from Senate, we still have those, but it remains to be seen in the next couple of months whether we are going to continue to have National Institutes of Health as we know it or not. So I'll just kind of end by saying that funding for this particular program of creating these types of clinical networks is coming from NCATS, but also from NIDDK and National Institutes of Child Health and Disease. NIDDK also supports these digestive disease research core centers, which Dr. Moghe talked about. And we are very blessed to have Pittsburgh Liver Research Center that I founded in 2016 here at University of Pittsburgh. It's only one of the 3 centers that's liver focused in the United States of America. The other 2 being Yale, which is where Mike Nathanson, who's a dear friend, and Jim Boyer, who's a dear friend, took care of you. So it's a great center. UCSF is the other center, and University of Pittsburgh Medical Center is the third liver center, which we have successfully renewed just 2 years ago for 5 more years. So What we do at the center is to bring all community across different departments together. We have about 80 members. These are members from medicine, from surgery, from pediatrics, from computational systems biology, from immunology, from pharmacology. But anybody who can spell the word liver, we want to have them be part of our group. And the goal is for us to then collaborate and fight liver diseases. So we have been very fortunate to be able to bring about $32 million annual funding from National Institutes of Health to fight liver disease. These are very active 42 labs that are working day and night to kind of treat liver diseases. And what Liver Center provides them innovative technologies to do deep analysis of patient samples, of animal models, and it's been very, very successful to kind of see, very gratifying rather to see a lot of this success now translating into patients. We also provide seed funding for our young investigators who are wanting to write larger grants, want to do large impact science in liver space through our pilot and feasibility program. We give them about $50,000. I would be remiss if I don't acknowledge the support of Community Liver Alliance. Susanna has been a worthy partner, and we have together jointly funded a couple of our pilot and feasibility recipients as well. So thank you for doing that. And of course, there's a lot of continued learning where we learn from each other. We invite seminar speakers once every 2 weeks, and these are individuals who are nationally and internationally recognized in liver space. They're physicians and scientists, and we learn from them, and they get to see what we are doing here. So it's been a very nice and gratifying journey for me to build community around liver. So thank you so much, and I appreciate your attention. Yeah.
Thank you, Dr. Monga, for sharing that information. And I do hope, as we all do, that we continue to get funding in the liver space and in the rare disease space. And thank you for sharing the details about PLRC and all the great work that you're doing. So finally, we have Leticia Marino. She is a patient advocate for PBC, or primary biliary cholangitis. She's a mom of 2 kids. She was diagnosed with PBC in March of 2020, and now she's really passionate about advocacy in the PBC space, education, awareness about the disease. And what she likes to highlight is that living with PBC brings difficulty in different walks of life, in different facets of everyday life, which is not really seen in clinic all that much unless you are probing deeper. And it's a very important space to kind of advocate about and talk more about. So thank you for doing that. And thanks for being here to share your story.
Thank you, everybody. I'd like to start off with thanking the CLA for making it all possible for us to be here today. I'm very honored to be here speaking with all of you today. As the great doctor here said, my name is Leticia Marino. I am a very blessed wife of a man who is exceedingly supportive and loving to me, and I couldn't ask for a better husband ever. My 2 children are amazing human beings. I have a son who is 22, and I have a daughter who is 20, and she's actually here with us today. She's turning just as red as my dress is, so you know. And side note with my daughter, with PBC, one of the most common indicators is an elevated alkaline phosphatase liver enzyme test, and my daughter has already been through the roof with her alkaline phosphatase. And I'll touch on that a little bit here in my speech, so just a little bit of a warning. I'm not a professional, I'm a patient. I've been living with PBC since 2020, well, essentially 2018. But what I do have is my experiences, and the experiences are not always pretty. So, buckle in and bear with me. I will start off by saying that in 2018, I tested positive for the anti-mitochondrial antibody. My primary care physician informed me that this is indicatory of primary biliary cholangitis, which is known as PBC, and that I most likely have it. He informed me that PBC is considered a terminal illness, and he also informed me that I most likely inherited it from one of my parents. I'm still to this day not sure which one it was, but I have theories that it's from my mom's side because my grandmother died of liver failure of unknown origins, and I'm betting they did not test her for PBC. So my primary care physician who tested me for the AMA antibody told me that I needed to seek out a gastroenterologist so that I could get my PBC diagnosed confirmed via biopsy. And then he just led me along my journey with PBC. The thing is that it took me 2 years to find a competent gastroenterologist who would perform a liver biopsy. For 2 years, I was lied to about their knowledge, and upon testing them about certain knowledges, one of them even admitted to me, even though he previously told me he knew about PBC, he had no idea what URSA was. And I had another doctor tell me, oh, well, you know, the antibody test that you took doesn't mean anything, just forget about it. That really comforted me. I had another doctor who said, well, you know, we'll just wait it out. Why don't you come back next year? Yeah, that works. And the story goes, for 2 years, I went without treatment. For 2 years, I sat on this information with no help whatsoever. So finally, on March 3rd, 2020, the results came in from my biopsy, and my diagnosis was confirmed for PBC. I wasn't given too much information about what to expect, where to go from there. I was given a prescription for URSO, and then I went home. I went home and I cried. I cried for 6 months straight. I felt alone. I felt helpless. I felt powerless, you know, to be honest with you. My gastroenterologist did tell me that I would be on URSO for the rest of my life. At that time, there weren't too many other treatments for PBC, and the very few that were available, he was not comfortable putting me on at the time. Since then, I am currently on Livdelzi. There's a nice gentleman in the back from Gilead who can talk to you about that. And I can say honestly, since I've been on it the past 2 months, my ALP levels for the first time have gone down. And I'm very confident it'll continue to go that way. So that's a little bit of a side note. So once I was through feeling selfish about my own health, it realized and it dawned on me, it hit me like a ton of bricks, you know, with the mommy guilt. And the mommy guilt, I'm telling you, if you are a patient, if you're a parent, you understand mommy guilt. But then you get told that you have a condition that's hereditary. And then the realization is, well, that means my children may one day have to face PBC. And that's my bad, that's my fault, because they have my DNA. And to tell you that that totally just shifted my views of how I'm going to treat my own PBC. And it was then that I vowed that I would do everything that I could in my power as a human being to find a cure, to try and make it right for my children. And the way that I see it is, you know, my daughter, she is 20 years old. PBC usually doesn't trigger, if it triggers, until about middle age. So I have roughly about 13 to 15 years to find a cure. And I am very determined to try and find one, and I need everybody's help for that. You know, PBC affects mostly women. It's said that 90% of PBC patients are female, but there's still that 10% that are male. And I have a son, and I've had to sit him down and explain this to him, that he's going to need to keep an eye on his liver. And it's such a difficult thing to sit your children down with and say, you know what, this is the situation, and I'm sorry, which, sorry, really doesn't go that far. And so forgive me here, I am having trouble reading because, I'm a little nervous. And so the PBC guilt and the mommy guilt is something that torments me to this very day. So then, since my PBC diagnosis, I have found it painstakingly difficult to find reliable information and treatment for my rare disease. This has opened my eyes to the lack of awareness and the importance of awareness for PBC. The fact that it took me 2 years to find a physician knowledgeable enough with PBC is not acceptable. Patients also should not have to educate medical professionals about PBC, which is something that I have to do every time I go to the emergency room. I have to go and talk to my optometrist about my dry eyes and said, you know what, PBC is making my dry eyes, my eyes very dry. And she's like, what's that? And, it's difficult to find mental health for coping with such a disease when your professional has no idea what you're talking about. And I have to teach her for that. That's not right, in my opinion. That should not be the case. And so this leads me to my main question is, what does awareness mean to you? It all starts with awareness. To me, awareness is the first step to improving and saving lives. Awareness in itself is not a goal, but instead a tool used in informing the public and professionals of needs that have yet to be met. The need for grief counseling and support for patients and caregivers in coming to terms with their diagnosis, helping them understand that we are not alone, and guiding them toward resources such as how to find support groups online, and the fact that there are support groups on social media. And like for me, I use Facebook a lot, and I'm very happy to see that PBCers are here because I am actually, a member of their support group on Facebook, and they have helped me tremendously. That's how I stopped crying in those 6 months, is I found those support groups. I realize I'm not the only one living with this, and I felt like kind of a pariah, like, okay, we're just going to put you over here because you have something that nobody understands. These people understand because they're living it themselves. And trust me when I say that that is empowering, and knowing that you are not alone. And let's see here, I'm sorry. These support groups offer patient-to-patient support, both online and sometimes in person. This type of support coming from people who can quite literally relate to your situation is invaluable to somebody feeling lost and alone. The need for advice and encouragement on how to inform your loved ones of your diagnosis, which can be quite difficult and scary to do. I would have to say that the most difficult one for me to tell would be my mother. I lost my brother to colon cancer when I was 14. My mother has already had to bury a child. So coming to her and say, hey, Mom, I was just diagnosed with a terminal disease, that's not the easiest thing to tell your mother in any form, even if your mother has never had to suffer the loss of a child. So another need we have is the need on how to live your best life with PBC, which is possible. This includes tips on which foods and beverages are best and which are worst for your liver. And the good thing about having this information is it offers a proactive approach to living with PBC, and it gives you just that little tangible bit of, hey, you know what, I have some power over this and I can do it. I don't have to just depend on these medical professionals. Another need that we have is the need for further education for all medical professionals, as I said before, including emergency medical staff, mental health professionals, and, as I mentioned, the optometry and other sectors, because PBC does not only affect your liver. The need to empower patients with the knowledge that it is perfectly acceptable to fire your physician. If your physician is not meeting your needs or if they refuse to take your cares and concerns seriously, you have every right to find a doctor that will make you feel heard and cared for. After all, you are trusting these people with your lives. I have a general rule that if I wouldn't trust these people with my mother's life, then why would I be trusting them with mine? You should have a trusting relationship with your healthcare providers, and extra points if they know each other like some of mine do and they work together. The need of making it publicly aware that PBC is an autoimmune disease and putting an end to the stigma that PBC is alcohol related. I couldn't tell you how many people assume that PBC is alcohol related, especially medical professionals when I go to the emergency room. The need of making clinical trials more readily available and the importance of patient participation. Laboratories and pharmaceutical companies cannot offer new treatments without willing patients to sign up and try them out. They will, I'm sorry, I missed a sentence there. The FDA will not usually, not never, but not usually approve new medication or treatment without at least one successful clinical trial. So let that sink in a little bit. If you want treatment, you need to be proactive. The urgent need to revisit and revise requirements for getting on the transplant list. Currently, patients with a MELD score of less than 15 are often not allowed on the waiting list to receive a liver transplant. This MELD score requirement has left many patients to depend on trying to find a living donor, or to be left, if they cannot find a living donor, to perish without a life-saving liver transplant. I have been made aware through some of my different social media support groups of PBC patients who have lost their lives simply because their MELD score was not high enough to get on the list. I have also been made aware of patients that have lost their lives while on the transplant list because by the time they finally got on it, it was already too late. I will be brutally honest with you, and I hope that I never have to get to that point where I need a liver transplant because I am absolutely terrified of my outcome. Because especially when it comes to PBC, there's a lot of different factors that go into your MELD score, and oftentimes PBC patients fall short with their MELD score. It's a highly common thing amongst PBC patients, judging from what I know through my social media support groups. The final and the most important for PBC patients and what we need that I will discuss today is the undeniable need for a cure. There's no question that if we solve the problem and it's actually curable, we could save the lives of so many people, so many generations. In conclusion, I implore you all to help me raise awareness for primary biliary cholangitis. If you are a patient, please, I beg you, join a clinical trial. If you are a caregiver, help others understand that the fatigue and symptoms of PBC are real, even if your loved one is not showing external symptoms. If you are a medical professional, take the initiative to expand your PBC knowledge and encourage your colleagues to do the same. If you are a pharmaceutical representative, encourage your company, please, to get back into that lab and help us win this battle against primary biliary cholangitis, because only together will we save the future, the lives of current and future patients of PBC. And I would like to thank you all for your time and attention in hearing me out today. And may you find the courage to make a change that you can all be proud of. Thank you.
Let's hear it for our panel. So brave and so wonderful patients to share their stories with us. And Dr. Moghe, we will not be taking questions because we're woefully over time. So we will go to our breakout sessions now. Breakout session, autoimmune liver disease in special populations is here with Dr. Moghe. Current research in autoimmune liver diseases with Dr. Kim is in the Reflection waterfront next door. And then our second set of breakouts will happen 20 minutes after that. And we'll try to get back on track. Thank you.